Hello, everyone, and welcome to this RPTH Research Recap. We are going to dive a little bit deeper into the science that is being published in RPTH. My name is Lana Castellucci, and I'm an associate editor for RPTH. I am pleased to introduce Dr. Maria de Winter, who's going to be with us today to share an exciting paper that was recently published in RPTH. Maria is very experienced in thrombosis research, and she's a clinical epidemiologist. She completed her PhD and is now working as a resident physician in the Netherlands. And we're really excited to have Maria here today to talk to us about a paper that was published called Balancing Risks of Recurrent Venous Thromboembolism and Bleeding with Extended Anticoagulation, a decision analysis. This is a really important topic for all of us that do thrombosis medicine because we are often faced with challenges of determining a patient's risk of both recurrent VTE and bleeding. So it's wonderful to have Dr. de Winter here with us to talk about her work. For those of you that are joining us live, we very much appreciate having you here with us. And if you have any questions or comments, please type them into the comment section, and we will be sure to ask them towards the end of our presentation. I am now going to hand this over to Dr. de Winter. Thank you.
Thank you for the introduction, and also thank you a lot for inviting me here for this research recap session. As already mentioned, I would like to discuss the methods and results of our decision analysis project. First, to give a brief introduction, deep venous thrombosis and pulmonary embolism, together venous thromboembolism, are treated for at least 3 months of anticoagulation with the aim to prevent thrombus enlargement, embolization, and early recurrence. And after this initial treatment, a decision must be made to stop treatment or to continue indefinitely. Guidelines recommend to extend treatment in patients with a high risk of recurrence, such as those with unprovoked VTE or VTE provoked by minor transient risk factors. And guidelines suggest to stop treatment after the initial treatment in patients with a low estimated risk of recurrence, such as patients with major transient risk factors. In those in whom indefinite treatment is to be considered, guidelines recommend to weigh risk of recurrent VTE and risk of bleeding while taking into account patients' preferences. Easily said, but in clinical practice this can be very difficult, as up till recently it was not yet clear how to estimate these risks for individual patients. In a previous project, we developed 2 competing risk-adjusted models for adult patients with VTE, the VTE predict models, and they can be used to predict recurrent DVT and PE, and clinically relevant non-major and major bleeding in a time period of 5 years after the initial treatment of at least 3 months. And these models can be used when deciding to stop or continue anticoagulation after the initial treatment. The models are integrated in an online calculator, which is available on the website you can see on the lower side of the screen. These models predict risks without treatment, and then in the calculator you can choose a type of anticoagulant treatment or platelet aggregation inhibitor and see how this influences risks of recurrent VTE and risk of bleeding. These percentages can then be discussed in clinical practice with your patients to decide together on what type of treatment would be best for your patient. However, these numbers only represent the risk of having an event and do not take into account case fatality rates, risk of long-term complications such as post-traumatic syndrome, and quality of life associated with these events or complications, nor do they take into account costs or patient preference. Therefore, in this project, we aim to determine the optimal weighing ratio between VTE recurrence risk reduction and increasing risk of bleeding in terms of quality adjusted life years, as this is an endpoint that includes both quality of life, case fatality, and would therefore be interesting to look at. In addition to determining the optimal ratio, we also compared a situation in which VTE predict using the optimal ratio is compared to current standard of care. For this project, we used data of adult patients with venous thromboembolism after at least 3 months of initial treatment without active cancer. We simulated data based on the bleeding risk study. The bleeding risk study is a multi-center prospective cohort study, which was started to develop a new bleeding risk score. And in this study, patients with unprovoked VTE and provoked VTE and a history of VTE were included. And all of these patients in the study, at least, were on extended anticoagulation. We used data simulated based on this study. For all simulated study participants, we used the VTE predict model to predict recurrence risk reduction and increase in risk of bleeding with treatment. We then simulated what would happen in different scenarios, starting with the scenario in which we assign extended treatment for all patients in whom recurrence risk reduction outweighs bleeding risk increase. Then bleeding risk is adjusted with different ratios ranging from 0.1 to 10 to simulate situations in which a patient would want to put more weight on preventing VTE recurrence or preventing bleeding. And different scenarios were analyzed. Then we used a microsimulation model to estimate 5-year risk of recurrent VTE, clinically relevant bleeding, and quality-adjusted life years in this total time period to compare these across scenarios. All scenarios were run multiple times, 1,000 times, and we used the pooled results of all of these probabilistic analysis. All patients are first assigned extended treatment or are to stop treatment. So patients all start in healthy state, either treated or untreated, with a certain health value in line with the Canadian population. Then the 5-year follow-up time was divided into cycles of 3 months. And at the end of each cycle, patients could proceed to a different health state or remain in the same health state. Patients could experience different events. For example, on the left side of the screen, types of recurrent VTE events, such as recurrent DVT or fatal PE, and also different types of bleeding. For these events, we use the VTE predict models to predict the probabilities of patients having these events in one cycle. And we used probabilities from literature to estimate the probability of different subtypes. Patients could also experience long-term complications, such as post-traumatic syndrome or impairment after intracranial bleeding, and patients could die from other causes, for which we used a newly developed Weibull model. So patients transitioned across states, thereby simulating their course of disease or course of life in 5 years. And after this 5-year time interval, all events and quality-adjusted life years were summed. This table shows the baseline characteristics of the study population. As we simulated data, you can see that the characteristics of our simulated data set were kind of the same as the bleeding risk study, although we had more patients. 36% of patients was female. Patients were 60 years as mean age, and 89% had unprovoked VTE. On this slide, we see the results of the models. Here in figure A, if we look at the x-axis of the figure, on the left side, we see a ratio of 0.5, for example. On this side, this corresponds to a situation where a patient would place more weight on preventing. In this situation, as we really want to prevent recurrent VTE, we see that 100% of patients is on extended anticoagulation. And if the ratio increases to the right side of the figure, we see that the more weight we place on wanting to prevent bleeding events, the lower the proportion of patients who is assigned extended anticoagulation. The dotted line represents what would happen if we treat patients according to current clinical practice. If you continue anticoagulation in those with unprovoked VTE, and at least if they don't have a high risk of bleeding. So then we would treat around 40%. In the next figure, we see what the effect is of treating all versus treating none on a number of events. On the left side, if we treat all patients because we really want to prevent VTE recurrence, the blue line shows that we have a very low number of VTE recurrence events, but a higher number of bleeding events, as is shown in red. On the right side, if we treat any patients, the number of bleeding events is low, but the number of VTE recurrent events is higher. The total number of events is a bit higher, as it's represented in gray. And the black line shows that the number of fatal events is actually quite comparable across all scenarios. In the last figure, we see the number of quality-adjusted life years across ratios. On the left side, if we treat all patients, the number of quality-adjusted life years is higher, whereas if we decrease the proportion of patients on treatment, the total number of quality-adjusted life years is lower. The optimal ratio, resulting in the highest number of quality-adjusted life years, is found to be 0.90, with a wide confidence interval of 0.51 to 3.4. In the optimal ratio scenario, 99% of patients is assigned extended anticoagulation. However, if we compare this optimal ratio to the least favorable ratio, which was found to be 5.1, in this situation, no patients were on extended treatment. The difference is only 93 quality-adjusted life years per 10,000 patients in 5 years. This comes down to a difference of less than 1 day in perfect health per person per year. In the standard of care scenario, which is also shown as a dotted line in figure C, we see that the number of quality-adjusted life years is kind of in the middle of the whole spectrum of ratios. The difference of quality-adjusted life years with this ratio and the optimal ratio is 44. So that's also a very small difference. In this study, we have identified an optimal ratio between recurrence risk reduction and bleeding risk increase of 0.90 with a very wide confidence interval, which includes actually a situation in which almost everyone is on treatment and a situation in which hardly anyone is on treatment. So therefore, we would say that we were not able to identify an optimal ratio which could actually be used in clinical practice. Our results show that in this population, when deciding to stop or continue anticoagulation, both prescribing extended treatment and stopping treatment after 3 months are equally valid treatment strategies. However, in this main analysis, we did not take into account costs associated with events, but also associated with treatment, and we did not take into account the burden associated with being on anticoagulant treatment, such as other side effects or the stigma of being on anticoagulation. It could be possible that taking this into account, prescribing extended anticoagulation to a majority of patients wouldn't be the most the most ideal option for most patients. So what our results do clearly show is that shared decision making is essential in a situation when deciding to stop or continue treatment. This were the most important conclusions. I would like to thank you all for listening, and I would like to thank all co-authors and other people who collaborated in this project a lot for all their contributions. And I'm happy to answer any questions that you might have.
Thank you very much, Dr. De Winter. That was a great summary of your work. This is a really important study, and it comes in a very timely time in the month of March, because in North America, this is Blood Clot Awareness Month. And so this is a really important paper that highlights the importance of incorporating patients into our decision making. And we're learning more and more about that. And you spent a great deal of time during your PhD work really identifying the importance of including patients in decision making and modeling. And so while we're waiting for some of our viewers to add in some questions, I have some of my own, and one that I'd really like to get your views on is, if you are seeing a patient in your clinic and you're at the point of having a discussion about potentially extending anticoagulation, how do you approach that with your patient? And maybe you can walk us through some of the things that you try to educate them about in terms of risk and what that discussion might look like.
That's a very interesting question. First, I think the VTE Predict calculator provides these risks, but I think it's not the best way to start to just give these risks to a patient and say, okay, what now? What shall we do? I don't think that's how it works. I think what's important is to get to know your patient first, to get, although time is limited, just to a little bit get to know what they like to do in their daily life, what's important to them, because that has a very big influence on how they will perceive the whole decision making regarding anticoagulation. For example, if someone likes to work out, to mountain bike or play soccer, or things that make it very difficult to be on anticoagulation, that has an important influence on their decision making. Or if they are very worried to have another VTE event and they want to prevent this at all costs, it's important to know this. But maybe they won't give you this information immediately when you ask them, do you want to continue treatment? So you need to get to know them first. And not only about the decision itself, but also the way they want to be involved in decision making, I think. Because some people will want to be involved and they did research themselves, they have a lot of things they want to discuss, a lot of questions, but other patients don't really want to be responsible for the decision themselves, and they will feel left alone if you have them make the choice just by themselves. So that's also something I think it's very important to explore and to try to involve them to the extent that they want to be involved.
Yeah, that's great. And I agree. It is really important to identify what activities they enjoy doing and how does that impact their daily activity and their daily lives. And, although the average age of the patients in your study was 60, oftentimes we see patients that are a lot younger with VTE. And the decision making around recommending extended anticoagulation can be a little bit more challenging in a younger population because the burden of medication is a consideration. They're not often on other medications. And so this may be the only medication they're taking, and it may not really fit with their lifestyle based on other things that they enjoy doing. One of the things that I find sometimes challenging is, patients that you mentioned may have a fear of a recurrent blood clot because they remember the symptoms of their initial blood clot, but they haven't experienced a bleeding event. And so it can often be difficult to explain that risk of bleeding when they haven't experienced a bleeding concern while on anticoagulation. And so trying to convey that risk can sometimes be challenging. Do you have any tips about how maybe clinicians can approach that?
Yeah, that's a very difficult issue, and I think something that deserves more research. In previous projects, we've looked into patients' perspectives on the decision to stop or continue anticoagulation. We conducted a study in the Netherlands in which we interviewed patients who had VTE but who didn't have bleeding. And we saw that many patients were very focused on preventing recurrent VTE because when they got their PE or DVT, they were told that they had a condition of which they could die, what's very dangerous. But then they were also sent home with treatments, which would kind of save their lives. That's how some patients felt this. So that moment was very influential for many of these patients, and they still bring that with them in the decision after a couple of months. So that's why in a next project, we interviewed patients who didn't only experience VTE, but also bleeding. This was one of the projects I worked on while being in Ottawa 2 years ago. Was also recently accepted for RPTH, so you'll come across that later, I think. And then we saw that even many patients who experienced bleeding as well, some of them still were kind of focused on preventing recurrent VTE, and we found that was very interesting, but also something doctors should be aware of to I don't know, maybe from the start at the emergency department already make sure that they get like a more balanced view or something. But it's something that deserves a lot more research, I think.
Yeah, absolutely. Thank you for that. It is important. The messaging around initial VTE diagnosis does really stay with patients for a long time. And I have also experienced that with many of my patients saying they were told they could have died from their blood clot. And so that's really important messaging that we need to share with our colleagues who may be involved before we are. And I agree. There's a lot of great work that your group is doing and yet to come. I'm just going to transition for a moment to a question from one of our viewers, and it's a question about the study looking looking at, first they want to congratulate you on your great work in your presentation, but also wondering if you can comment about whether or not vitamin K antagonists were incorporated into your modeling, and if that difference was compared to direct oral anticoagulants.
Yeah, thank you for this interesting and relevant question. In these models, we used a pooled estimate for the effect of full dose DOACs. We didn't use vitamin K antagonists because DOACs are most commonly used now in most countries at least. And we used a pooled estimate for full dose DOACs because there's no head-to-head comparison yet to show if one of them is better than the others or if there's a difference. We wanted to make the results generalizable. We didn't choose low dose DOAC because the data on low dose DOAC is relatively scarce. We did include a sensitivity analysis on this, but these estimates were only based on 2 small studies. So that's why we chose full dose DOAC.
Great, thank you for that. And Maria, maybe you can tell us a little bit more about the next steps in terms of your work and work of others perhaps, and how incorporating patients into decision-making can be done both clinically and from a research perspective. How do we incorporate their concerns and their values, and what are the ways that we can do that in a continuous fashion? If you can maybe summarize some of the work that you're doing, and if you know of others' works, that would be great.
I think many next steps, there are of course next steps in the whole modeling thing, but there are also a lot of interesting steps to be conducted in more patient-directed research. We used, for example, utility values based on previous research to incorporate the quality of life patients experience when having a certain event. There are quite some studies about this, but we see that confidence intervals of utility values for VTE, but also bleeding events are very wide. This kind of shows that there's a lot of variation in how patients perceive their VTE or bleeding events. And I think this heterogeneity really needs to be explored, why do some patients find an event more burdensome, and why do others don't really experience a lower quality of life with a certain event? So it's interesting, I think, to further look into, can we specify this a bit more? And then the next step, we can predict risks, and this improves a lot. But how to communicate these risks with patients, because we now have percentages, and we know that it's something that's difficult to handle for most doctors, so also for patients. So how do we show these risks? What do we, maybe figures or maybe something else? And I think that's also an area of research that is really required to get the most out of the models we're making.
Yeah, that's a really great point. How to convey that information to not only healthcare providers, but also to our patients can be challenging for both groups. So thank you for highlighting that. And, it's possible that although we have different tools and resources that we use to evaluate quality of life, perhaps we need to relook at some of those questionnaires and models as well, and perhaps incorporate some other factors that are relevant to patients and valuable to patients. And when we consider extending anticoagulation treatment, what does that mean? So some of those models may need to be updated as well from that perspective. So this is a really great summary that you've provided for us. Just in terms of one of our other audience members' questions is related to medication treatment adherence, and how do you convey the importance of that to a patient, both when talking about acute treatment of VTE, but also potentially for secondary prevention. What does that conversation look like, and how do you impart the importance of medication adherence and compliance?
Yeah, that's a very difficult issue, I think, because many patients who are not adherent will not tell you. So I think the first point is that it's important to try to work on your doctor-patient relationship to hope that your patient will actually inform you if they consider stopping or switching or not taking the medication. So then you can at least have a conversation about it. So I think that's where it all starts. Yeah, I think it's just important to provide patients sufficient information why it's important that they take the medication. Risks can help, but yeah, also yeah, what can happen when they don't take the medication, like make them really know why they take it, and not that they feel like, oh, I take this because the doctor told me I had to, but make them really understand. And maybe if you're not sure if they understand, ask them if they can tell why they think they are on the medication. And in our interview studies, we're sometimes a bit surprised what patients think that anticoagulation did. So I think, yeah, having them understand is important. And then we often see that patients start to self-manage, that they just skip a dose of anticoagulant when they're going to do gardening or something. Yeah, I think it's best if patients tell you and you can have a conversation about it. But I'm not sure if I know the ideal way of communicating about this, as I just started my residency.
No, that's
my thoughts.
yeah, you've highlighted some really important points, and a great way to ask that is to ask patients, what do they understand about VTE and the treatment of it? I think that's a great place to start. And sometimes you're right, they don't necessarily indicate to you that they're missing doses of their medications, and there's other ways to ask it. Is a strategy that I've found over the years, that sometimes you need to ask, how many times in a month might you miss your medication? And they might be able to share it in a different way. But you highlight some really good points, and I think that's an important factor when we look at these risk models of extended anticoagulation, is factoring in medication compliance and adherence. So that's great. Dr. De Winter, I'm just going to begin our wrap up, if that's okay with you. And I would like to thank you very much for being here with us today to share your presentation and your great work. Congratulations to you and your team. It's been really awesome having you. And I would just like to thank our audience members for their participation and their questions. We at the ISTH and RPTH and JTH, we are very excited about the month of March as Blood Clot Awareness Month. And as you know, we have World Thrombosis Day as one of our ISTH campaigns. And our theme for this year's World Thrombosis Day is Move Against Thrombosis. So this is a great way to incorporate risk reduction for you and your patients. So please keep that in mind. If you would like to learn more about World Thrombosis Day, please go to worldthrombosisday.org or the ISTH. And we'd very much like to have anybody who's interested in joining us let us know. So thank you, everybody, for being here today. And Dr. De Winter, thank you very much.
Thank you a lot.